medical, legal, and ethical issues, of which we encounter a lot of these in our daily work in pre-hospital. We're going to look at the scope of practice. Now, that's a phrase you need to be very familiar with. You need to know what it is. Scope of practice. So write that down so that you know that, you be sure that you understand it. We're going to look at consent. Patients have the ability to decline care. They can say, no, I don't want you to treat me. And you have to honor that in most situations. We're going to look at some legal concepts. We're going to look at negligence. We're going to look at torts. We're going to look at abandonment. And these are all terms that you need to be very intimately familiar with so that you don't commit any of these acts. We're going to look at the definition for duty to act, this legal definition for duty to act. We're going to look at what your responsibilities are on a crime scene. Because there are certain things we do, certain things we don't do. So those are most of the things that we're going to be looking at here. We've got a few other legal issues we'll throw in, but most of them we're going to focus on our scope of practice. We're going to look at consent and refusal. Consent and refusal, or refusal in particular, is the most common reason for an EMS provider to be pulled into court. It's going to be over refusal. So we're going to look at how to manage those so that we don't go to court. So, scope of practice. Does anybody remember reading that in the textbook, what it said about scope of practice? No, not so much. I didn't read that. Well, good news for you is I did. The scope of practice are the regulations and ethical considerations that define what we can do, the extent and the limits of our job duties. Scope of practice. So when you leave here, you graduate, you get your license, there'll be certain things that you can do and certain things that you can't. So your scope of practice will include pretty much everything that you learn in here and anything that's defined under EMT duties that you can do. Now, that's going to be a national standard, but each state can define the scope of practice for their practitioners. For example, when I initially got licensed, I was in California, and we could do anything. If you could think of it, the doctors let us do it. And I moved to Florida. Florida's pretty much the same thing. Your medical director could determine what exactly you did. And we did a lot of stuff. But he could kind of expand your scope legally that way. But they can also narrow your scope. So I moved to Alabama, and in Alabama they have a more narrow scope. Like in Florida, we can use paralytics to paralyze a patient so we can intubate them. Here in Alabama, we are not allowed to do that. In Florida, we can do a cric on a patient that has a blocked airway. We can cric them. In Alabama, we can't do that. So the greater scope of practice includes all the things that you as an EMT are trained to be able to do. However, wherever you are, your service or your medical director or your state can limit your scope of practice. On the EMT level, I remember in Alabama and Alabama and Florida, in EMT can do a sugar stick. They can poke your finger, draw some blood, and check your blood glucose level. But in Mississippi, they consider that invasive, so they won't allow EMT to do that. But it's part of your scope of practice, whether they allow them to do that or not. So that's really what scope of practice is. It defines the extent and the limits of your job duties. May include skills and procedures, but it may be other things too that we'll talk about here in a bit. They're defined by national, state, local laws, statutes, or protocols. So there are a lot of input into what you can actually do. There's that big umbrella of all the things that you're trained. Like our paramedic students are trained to paralyze. They learn all the paralytic drugs. We teach them to cric a patient. They practice it. They know how to do it. But in Alabama, they can't do it. But they may not always be in Alabama. They might move to Florida, or I don't know what they do in Georgia. I haven't figured that out yet. Now, another concept you need to be familiar with is standard of care. This is different than your scope of practice. Your scope of practice defines all the things that you can do. The standard of care really reflects how you do your patient care, how well you perform your patient care. So it really speaks to quality more than anything else. Standard of care is the care expected from an EMT with similar training for a patient in a similar situation. So if I'm in California and the patient has a head injury, I would expect to treat them a certain way no matter where I am. So when they talk about the standard of care, that means that any paramedic anywhere in the country should treat that patient essentially the same way. You know, if you've got a patient with chest pain, one of the things we'll be given as EMTs, we'll be giving them nitroglycerin. That's an expected standard of care. So if you have a chest pain patient and they have a prescription for nitroglycerin, they would expect you to do an assessment on your patient, make sure you determine that they meet the criteria to be given this nitroglycerin, and that you provide that for the patient. If you fail to do that, then you have failed your standard of care. So it's meeting the standard of care that any EMT in the same situation, the same type of patient, would provide the similar level of care. Does that make sense? Sometimes I sound like I'm talking, I'm not making any sense. If you meet your standard of care, it greatly reduces your chance of interfacing with the legal system, which is something you want to keep at bay at all times. So the scope of practice is what you can do. The standard of care is how you should do it. Does that make sense? Scope of practice, I can do all these things. My standard of care is how well I should do it. So that's a good distinction for you. I'd write that one down. Students do confuse these. That's why I put that on there. Scope of practice, that's all the stuff you can do. Standard of care is how well you do it. Or do it or not do it. Okay, let's look briefly at ethics. Ethics are morals or standards that govern the things that you do. Some things are legal and they're not ethical. Can you think of anything? No, I can't think of anything. Okay, a common one I use is back in the olden days, in the days of slavery. Was slavery ethical? Absolutely not. Was it legal? Yeah. But just because it's legal, that doesn't mean that it's ethical. So you want to treat your patients ethically. Like, even though I can start that 14 gauge IV on you, which a 14 gauge is about this big, I legally can do this. Ethically, I should be ashamed of myself for doing that if you have a head cold. So yeah, some things are legal, but they're not ethical. For you to act ethically is not always required by law, basically what I just said, but if you will apply the golden rule, do unto others as you would have them do unto you, or treat others, or treat that patient as you would want to be treated in the same situation, you're probably okay. If you always keep the best interest of your patient in the forefront of your mind, then you will act ethically and morally. Good ethical behavior, that is the way you're going to act or respond when nobody's looking. You know, if nobody's watching you, are you still going to do what's right? Just because you can get away with it doesn't mean that it's right. So good ethical behavior is what you do when no one's watching. The single most important question you have to answer if you have an ethical question, you know, gee, what should I do here? If you think about what's in the patient's best interest, then you'll do the right thing. If this was my grandmother, how would I want her to be treated? Or your mom, you know, somebody that you like. Don't use somebody you don't like. Okay, let's look briefly at consent and refusal. And let me say one quick thing. There's a lot more material in your textbook about these topics, so I absolutely require you to read your textbook. I will probably tell you 80% of what you need to know, but the other 20% is going to be in your textbook. And you will get questions on your exams that come from your textbook that I haven't said in class. And I do that specifically to make sure you read it. Because as I said at the beginning, National Register can ask you anything. I mean, all bets are off. They don't send me a notice and say, did you tell your class about such and such? Because if you didn't, then I won't test them on that. They don't do that. So anything in your book is fair game. So I want to make sure you read it. And I know from personal experience, I remember going into registry and having questions that I know they didn't cover in class. I know specifically I had a test question that asked about Christmas. Does that sound familiar to anybody? Christmas? Christmas. And I'm going, I remembered reading it because I'm a reader-writer. So I remember reading that, so I got that question right. But I remember coming back and telling my instructor, hey, you know what? You're not going to believe this word I had on there. And I said it, and he goes, what's that? And I went, oh, crap. So the important thing I'm trying to impart to you is you got to read that book in case I forget to tell you something. Or in case there's something in there that I may possibly not know, which is probably not in this book. But anyway, just be forewarned, you got to read that book because I'm not going to cover every single thing, and I'm not going to read the book to you. Or we could do that, but you guys would all be sleeping and snoring. All right, let's look at consent and refusal because those are such biggies. And there are lots of components to this, so there's stuff that you need to understand about it. So, patient consent, that is going to be permission obtained from your patient for you to provide care for them. That will include assessing them, treating them, and transporting them. Some patients, they say, yeah, go ahead and treat me. You know, assess me, treat me, do all this stuff, but I'm not going to the hospital. So they can refuse at any point. There's several forms of consent, and this can be confusing to students sometimes as far as the different forms of consent. There's express consent, and we're going to get express consent from a patient that is alert and oriented. You know, they can look you in the eye, they can talk to you rationally. These are the kinds of people that you'll get express consent for. Express consent also is informed consent. And that's another phrase we're going to deal with a little bit more too. So express consent doesn't mean you have to go up and say, is it okay if I take your blood pressure? Is it okay if I take care of you? You don't have to do all that. Most of the time they call 911. You walk in, they're looking at you like, oh good, somebody's finally here to help me. But if you go up, they make eye contact, and you start talking to them, and they don't make any motions to push you away, that's kind of, I don't mean they're going like this, but you know, you walk up to them and they start backing off, you know, and they start closing up, you know, like a night flower, then you know that they're kind of withdrawing from you. So then you want to take a little bit of time and say, hey, I'm here, you call 911, how can I help you? They start talking to you. If they don't make sounds like don't touch me, then that's basically express consent. You don't have to say, hey, is it okay if I take care of you? So you don't have to go that far, but you do have to be open to recognize their physical as well as verbal cues as to what you're allowed to do. Next is implied consent. For an implied consent, these are usually patients that don't meet the legal definition to give you consent. In order for them to give legally acceptable consent, they have to be alert, they have to be oriented, they have to know what's going on. It can't be somebody that's drunk out of their mind. You can't take a refusal from them. So, express consent is somebody that is able to be informed, so they have to be alert and oriented. Implied consent usually is going to be an assumed consent. If you had a patient that was unconscious because they couldn't tell you that they wanted to be treated, does that mean you can't treat him? He's unconscious. He can't say okay, so I got to back off. Is that, you all okay with that? No. With implied consent, say you have a patient that's unconscious, you want to treat them as if they were conscious. A reasonable person would want care. Okay, if they're unconscious, their head's bleeding, a reasonable person would want to be cared for in that circumstances. So you would treat them under the doctrine of implied consent. So in this case, we will assume that they would have wanted care. We would assume consent. We can only assume that if they are not legally able to give consent. Does that make sense? And your medical director may give you some guidelines on how they want you to handle implied consent so that you kind of keep yourself out of trouble. Okay, here's one. Think about this. You have a patient, Bob. He's been having crushing substernal chest pain, which means crushing, like somebody sitting on my chest, substernal, that's going to be, this is a sternum here, so it's right in there. And he's got pain radiating down his left arm for several hours. What does that sound like to you? Yeah, he may be having a heart attack. He is cool and pale and diaphoretic. That's a phrase you'll get used to. Cool, we know what that is. The skin's cool. Pale, blood's drained out. Diaphoretic. Anybody know what that means? Yeah, he's sweating and it's not hot outside. So they break out, it's like a cold sweat. So you get that frequently with chest pain and other things. It's part of that sympathetic response. So he's cool, pale, and diaphoretic, and he denies, SOB means shortness of breath. It doesn't mean what you're thinking. He denies, or he says, I can breathe okay, but I have this crushing pain here, and my arm hurts. So you put him on some oxygen. He's got a prescription for nitroglycerin, so you've taken vital signs and everything. You've given him his nitroglycerin. So now he's feeling better. On a scale of 1 to 10, before the nitroglycerin, he tells you he's got pain of like 8 out of 10, 10 being the worst he's ever felt. So that's pretty bad. So through the course of treatment, you give him some oxygen, you give him some nitroglycerin, you give him some aspirin, and he's going, oh, I'm feeling a lot better now. And now he don't want to go to the hospital. Is that smart? No, no, that's not smart. So he's refusing. So you can't imagine why anybody with that much pain would refuse to go to the hospital, say whether his pain's gotten better or not. So what all can you do to try to get him to go to the hospital? You talk to family members, see if they can talk him into it. He doesn't have a doctor. You call the doctor at the hospital, you know, and he talks to him, and he still can't convince him to go. Can you take this guy? He needs to go to the hospital, doesn't he? Is he going to die? Probably, if he doesn't get some care. Can you make him go? You can't like just strap him on and take him. It's for his own good. Wouldn't you want to go to the hospital in that circumstance? Wouldn't you want your family members to go to the hospital? Why don't you strap him in and go, for heaven's sakes? Don't you care about him? He's going to sue you? Yeah, he probably would. He might, and he's probably going to win that one. Yeah, you can't make him go against his will. This guy's obviously alert and oriented. You know, he's told you what he feels like. You know, he's given you the whole background, you know, his whole history and everything. He's alert and oriented. You know, you tell him, you know, I think you're having a heart attack. This is not good. You need to go to the hospital. He goes, no, I'm not going. You can't make him go. So the elements of informed consent. I got my little things backwards here. Informed consent means that he understands the consequences of his decision. So this guy, say he's got substernal chest pain, great chest pain. Say now he's getting shortness of breath, his arm hurts, starting to feel dizzy, feels like crap. You have to inform him of what can happen if he doesn't consent. Because you're the educated person, you're the one that's supposed to know what happens. The lay public oftentimes doesn't know. For example, you may have a patient that gets hit pretty squarely with the airbag in a rear-end collision. The airbag pops open, some short girl that, you know, pulls her seat up really close and just pops her all over. Well, she's alert and oriented, she's conscious, and she goes, no, I don't want to go to the doctor, go to the hospital. You've done an assessment, you see some bruising here. She kind of says her chest feels a little bit tight, but she doesn't want to go to the hospital. Can you just say, okay, sign here? No, you really can't do that. I mean, you could do that, but you leave yourself open legally because the symptoms that she's described, plus the amount of energy transfer there, she could have a serious chest injury, and she doesn't know anything about it. So you want to say, you know, I'm concerned because you got hit very, very firmly with that airbag. You said your chest is sore, you know, you have a little bit of difficulty breathing. You could have, you know, lung bruising. You could have a collapsed lung in there. You could have bruised your heart. You could be bleeding internally. You need to go to the hospital so they can check you out and make sure you're okay. That's what informed consent means. You have to inform them of the worst case scenario. Now that doesn't mean every time you have to say, if you don't go to the hospital, this is going to kill you. But there are times that you'll say that. I've probably said that to a dozen patients. You know what? If you refuse and you go to the hospital, this is probably going to kill you. I've had a couple patients that they still refuse to go, and I mean, I watched the obituaries for several days after that because I knew they were going to die. So you have to inform them so that they can make an informed decision. So this patient, the chest pain patient we were just talking about, can he refuse? Anybody think he can't refuse? Yeah, he can absolutely refuse. So what should you do if he's saying, I'm not going to go? You've informed him, you know, I think you're having a heart attack. There's a good chance you're having a heart attack. This could kill you. He goes, I don't want to go. So what's your role? Do what? Yeah, you're going to use all of your persuasive powers. You need to let them know the risk. You know, there's a good chance, you know, that this could kill you. What else you need to tell them? What else you need to do? What can you do? What, in the back of my mind, I know what? I need to get this patient to the hospital, right? So what are some things I can do that might persuade him, or might I be able to get him to consent? Yeah, you make, is there somebody I can call? A spouse, a girlfriend, somebody that can talk to you? So yeah, try to get family members involved. You know, if your mom's sitting there just, oh, honey, you've got to go to the hospital, you're probably going to go just so she'll shut up, right? So yeah, try a family member. What else can you try?
No.
Do what?
No.
Yeah, call the ER. That's what those physicians are there for. You know, put them on the phone with the physician. Sometimes they carry a lot more weight than you do. And he'll say, you know what, Mr. Jones? I've just seen that EKG strip they just sent in, or based on what they've told me, you need to get here right away. We can probably help if you can get here. And that works a lot. What else can you do?
Figure out why I don't want to go.
That's a biggie. What is that barrier to them wanting to go? I'm going to tell you a quick story because it was so dramatic. Years ago, I was working in Foley, Alabama, close to the Gulf Shores, and we had a call way out in Fort Morgan. I don't know if you guys have been down there, but it is like, I mean, you need to take an airplane out there to the end of that peninsula. It's so far. So we had a chest pain patient out there, and my partner, who, Tilly passed away recently. That was very sad. He was a scary guy. He was 6'5", and he was an inch, and I'm telling you, he weighed 400 pounds, and he walked around with this embedded frown on his face, and I can tell he scared me to death until I got to know him, and then he doesn't scare anybody after that. I mean, he was just a pussycat. But anyway, he was a scary-looking guy, and so Tilly and I are treating this patient, and the guy absolutely would not go. His wife had called 911. He had subdural chest pain. It was this guy right here, as a matter of fact, the scenario, and he wouldn't go. We gave him some nitro. He didn't get any better. I looked on the monitor, and there's something we call tombstones because the shape of the EKG strip is like, this guy's fixing to die. So we knew this guy was probably fixing to die, and he would not go to the hospital. I tried everything I could think of to convince this guy. We talked to the family. We call this deadgum minister. You know, we ask him everything. You know, what is it? You know, they can help you. They can give you medications. If we get there in time, they may be able to reverse the damage, fix you up just as good as no. Why won't you go? I just won't go. I'm just not going to go. If I get worse, she can drive me to the hospital. And his wife is like just dying in the background because that's her worst case scenario. Should be everybody's worst case scenario. And I'm just like pulling my hair out. And I can't convince the guy to go. And I know he's fixing to die. So I know we're going to be back there in a matter of hours anyway. And I told him that. I said, you know, we're going to be back here in a few hours doing CPR running. Does that appeal to you? He goes, I'm not going. Lady, I'm not going. So I look at Tilly, and, you know, Tilly goes, so he walks up to the guy, scary old guy, and he goes, why didn't you want to go to the hospital? And the guy says, well, it's really expensive. I'm going, why did you say that? He goes, well, it's really expensive. Until he goes, you got Medicare? The guy says, yeah. He goes, they'll pay. Get on the stretcher. The guy got up, and we're gone within about 30 seconds. And the guy actually went into cardiac arrest. We were about 10 minutes out. And because we were there, we had all of our drugs. We had a defibrillator. We got a save out of it. He went on to have like a quadruple bypass something. And he called us a few weeks after that. And he goes, oh, thank you, thank you, thank you. And we're going, yeah, I wanted to kill you that day. But the bottom line here is I just hadn't found the right button. But Tilly did. It was about money, and I hadn't thought about that. And as soon as he hit on that button, said they'll pay, it wouldn't matter if they pay or not. They're not gonna, if you don't have the money, they can't get it out of a turnip, right? So anyway, find out what that barrier is that's keeping them from going. Sometimes it's Granny, and she just is worried about her dog. No, I can't leave my dog. Or they're worried about a family member, or who knows. I had a patient that refused years ago, and we knew she was going to die. I told her she was going to die. And she didn't want to go to that hospital because her friends had gone to the hospital. and they never came back. They all died there. I'm not going there because that hospital kills people. Well, we can probably go to another hospital then. No, I'm not going. I know what they do there. I'm not going. And she refused. So anyway, she died. So let's see what we have next. So informed consent. You need to make sure they understand what's going to happen to them or what you think is going to happen to them if they don't go, and then you have to document that. We'll talk about that too. Elements of consent. You got to tell them what you think's wrong with them. The girl that got hit with the airbag, you know there's a good chance that you've got a cardiac contusion here. You may have a lung contusion. Contusion means bruise. So they may be bleeding internally. So you've got to tell them, you know, with the knock that you got hit with that airbag, you could very easily have some bruising and bleeding in your chest. And you may not have a problem right now, but 2 or 3 hours from now, this could kill you. So yeah, you need to go checked out. Usually that works for them. Is it the truth? Could that kill a person? Yeah, I've seen it happen. So certainly. Recommended treatments. You know, you're having chest pain right now, but we can give you some nitroglycerin, and that should help relieve some of that pain. We can give you some oxygen. That might make you better. You know, whatever your treatment is that you're going to do for them, you need to tell them that. You need to tell them if there are any risks as well as benefits from treatment. When we give you this nitroglycerin, it'll lower your blood pressure. It'll help that headache a little bit, maybe not. It may, you know, relieve the pressure on your heart, so your heart doesn't have to work as much. If there are any alternative treatment possibilities, sometimes you may have a patient that's not fixing to die right now. You know, they've got a little bit of time there and they're absolutely refusing. You might say, is there anybody here that can drive you to the hospital? Or, you know, maybe you could see your doctors or somebody that could take you to the doctor. So you may offer some alternatives if it's an alternative that you're comfortable with. You know, the guy with crushing chest pain that didn't want to go to the hospital, it's not a good alternative for his wife to drive him to the hospital, because what that means is she pulls over sometime whenever he goes into cardiac arrest and tries to do CPR on him on the side of the road. So that's not a good alternative. But if it's a good alternative, then you can mention that to him. You need to let them know the dangers of refusing treatment and transport. You know, if you don't come to the hospital and get checked out, there's a good chance it's going to kill you. It's just going to kill you. There's nothing wrong with saying that if there's a chance it's going to kill them. You don't want to scare anybody needlessly, inappropriately. Now, consent for children, that's a whole different thing for minors. And it's a little bit different even here in Alabama. Kids cannot refuse care. You know, if you've got a 7-year-old, he don't want to go in the ambulance and he's kicking and screaming and carrying on, you know, his parents say whether he goes or not. It's not up to the child. And in most states, that goes up to age 18. Once you're 19, then you can consent and refuse. You can refuse. Here in Alabama, it's a little bit different. I'm going to tell you this just for your own information. It's not a registry question, but here in Alabama, if you're between, I think it's 12 and 18, you can accept care even though the parent is refusing care. So say you're a 14-year-old girl, you suspect that you're pregnant, your mom, your parents don't know, and they're saying she's okay, she just, you know, ate something really bad, she's got a stomach ache. And the girl's going, no, I want to go to the hospital. In that case, the child here in Alabama can ask for care, and you can provide care against the wishes of the parents if the child is over, I think it's 12 or 14, it's 12. But that's just in Alabama. So you'll need to know that down the road if you're practicing here, but for registry, certainly not, and that won't be a test question because we test to national standards. So kids are not able to refuse care per se. You have to obtain that consent from the parent or the guardian in most cases. There are some cases that are outside of that. There are a few exceptions. In loco parentis, that means in place of the parent. So say you get a call to the playground at the elementary school, and the principal's there, and they have all these signed releases of the parents, you know, and basically that is going to be in place of the parent being there and actually saying, yes, provide care. If you had an adult on scene, say he was, I had incidents where I was babysitting some kids, there was an accident, we called 911, I was the adult there and I accepted care for the child. Even though I didn't have the legal authority to do that because I wasn't the parent or the guardian. In loco parentis, I would be covered for something like that. Emancipated minors, that's another category of minors. An emancipated minor is a minor that meets the legal description or the legal definition of a minor who can make decisions for themselves. Can you think of any circumstances that would make you an emancipated minor? It what? That wouldn't necessarily make you an emancipated minor because they would probably, the court would appoint a guardian for you. You're thinking of, I like that. Yes, if you have a child, female, male or female, if you have a child, if you're pregnant, then you're considered an emancipated minor, which can kind of put us in a difficult position because you can have a 14-year-old that is like pregnant by a few weeks. There's no way for you to know they're really pregnant. If she tells you she's pregnant and she wants to decline care, then you got to go with it. Just make sure you get everything signed off. Emancipated minor usually is going to be somebody that's married underage, or they have children, or the courts have declared them emancipated. I think back in the olden days, none of you guys were alive then, but Michael Jackson got himself declared an emancipated minor when he was under 18, and he kind of broke off from the family. So you can get declared that by the courts for whatever reason. If the child has a life-threatening illness or injury, then you may be able to step in there to save a child's life, even though the parent is saying no, no. So that can be challenging if you've got parents, guardians with religious objections or cultural objections, to that. I would tread lightly on that. If you have instances like that, I'm calling the hospital and I'm putting them on the phone with the medical control, the physician there, because they really can make those legal decisions for you. If they say, okay, leave the child, then the monkey is on their back. So always use them as a resource when you're not real sure how to handle something. But usually in the presence of a life-threatening injury or an illness, usually the parents are going to be okay with it. But can you think of a circumstance where the parent might not be okay with it and it's not a religious objection?
Like an abuse situation?
Yeah, an abuse situation. It's not always the case, but that's something that I always would keep in the back of my mind. If they're refusing care, they don't want you to know that they've beat the stew out of them.
What do you do then? Can you call
Oh yeah, you bet.
you can call DHR or you just
Well, you're going to call law enforcement. If you have trouble getting a child out of the home or out of the setting because the family, the parents are saying no, 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 and you know that there's a severe threat to life or limb, I'm not leaving there without the child. So usually if you say, you know what, we're going to have to get law enforcement here. This child needs to be treated. Do you really want that on your conscience if this child dies and you refuse care? You will go to court over this. So the best way to handle this, let us take the child to the hospital. You do not want that to have to deal with legally later. Usually they'll relinquish and do that. But if not, your number one goal is to get the child out of that setting. So whatever I have to do to get them in the truck so I can get them out, I'll do it. But law enforcement's usually going to be one of your best friends here. Minors serving the armed forces, they're always going to be considered emancipated minors. Consent for mentally incompetent adults. Does this sound like drunks? Maybe not. Any adult who is incapable of making informed decisions. This could be a mental condition, where they have some mental retardation or something of that sort. Or it could be that they've got a bunch of drugs on board. They're not able to make a rational decision. This would include alcohol, any disease process, your patients with Alzheimer's or dementia. They would all fall into this category. There's going to be laws or protocols in place that help you determine how to manage this, but you can always call Med Control. We're going to treat these patients under the implied consent that if they were alert and oriented, if they met the legal definition of being, competent, then would they want care? Most reasonable people would. So then you would provide care in that instance. Involuntary transportation. We try to avoid this whenever possible, because if you're transporting a patient that is adamant that they do not want to be transported, number one, you're going to open yourself up to a lot of legal issues, but there's also a lot of physical danger that comes with transporting people that do not want to be transported. We're going to transport a patient that we consider a threat to themselves or others. You know, if they have said they're going to kill themselves, one thing you know about patients that will commit suicide, they don't think anything about life and they just soon kill you. You know, they don't care who they take with them sometimes. So anybody that would kill themselves, they could kill you also. So you want to recognize that threat. So those patients need to be transported to the hospital. In this case, you're going to need law enforcement to assist you. You may have a court order that orders them to be transported. We don't really see those much in the field because we run emergency calls. You get there, there's not going to be a court order usually for you to transport somebody. Usually requires a decision by a mental health professional or a police officer. This is not a decision that we want to make, you know, whether they should be transported or not in the event of, you know, somebody that's violent or whatever. You have a question?
So a police officer can make that call?
Well, we're just going to pass that monkey onto their back. In some states they can. I know in Florida they have, I can't remember the statute, but they have that allows police officers to say they're going to be transported. We can tie them down and hold them for 3 days for a mental evaluation. Alabama doesn't have anything like that, but if they're a threat to themselves or others, then they fall under that category that they can require transport.
Georgia has that also.
Do they? Okay. What do they call it? Some name to it?
But,
It's just tackle.
I mean, during post training, if you're anyone that has lost life to themselves or others, you're allowed.
To take them against their will. Yeah, you know, there are people like that. You just need to get them off the street. They need to be evaluated. They need to be medicated, treated, whatever. So I don't want to make that decision. I'm going to call med control or let law enforcement do that. Now, if you restrain a patient, you kind of wander into other legal issues. You've got to make sure that you restrain them in such a way that you don't kill them. You want to kill them sometimes, maybe yes, but that's not permitted. So you have to restrain them in such a way that you are absolved of liability. You can't tie them down, face down, you know, in a pillow. That looks really bad. You get to the ER and they're dead. I don't know what happened here. So you have to make sure that you restrain them in such a way that it's humane. You know, you can't restrain them with big old chains around here and then you like knot it with a lock to the stretcher. You can't do that. You should need to use some soft restraints or something. And all the ambulances have something that's humane. So you'll use something like that. Refusal of care. Patients may refuse care and transport. They just can't. You're going to do everything you possibly can to prevent that, but sometimes that's all you can do. You're going to get them to sign. You go through all those steps we've talked about so that you can take a legal refusal, and then you just got to leave them. They have to be legally able to consent or refuse. That means they have to know what's going on. You have to tell them worst case scenario. You have to tell them what you're going to do for them. You know, if you don't do this, this is what's going to happen. You have to go through all those steps, trying to do whatever you can to transport them. And if it's still a no-go, then they can legally refuse. But you have to be sure they know what's going on. You can't let them refuse just because you don't like them, just because they woke you up at 3 o'clock in the morning and you're in a bad mood. They have to be mentally competent and they have to be oriented. Oriented, we're talking about person, place, time, and event. Who are you? What time is it? Do you know what's going on? You know where you are. Those are elements of being oriented. They have to be fully informed of the risk, and then they need to sign a form. Now, that signature doesn't either absolve you or incriminate you in any way. The signature is just a way that you can document, yeah, he knows all this stuff, and he said no. What if he doesn't sign it? Does that mean all that work's for nothing? Okay, I had a patient one time who refused to sign. He threw the pen all the way across the ambulance. Does that mean that the document is null and void? Yeah, I just wrote on there, patient was very irritable and refused to sign, threw the pen across the room. That's it. I did my best to get him to sign. He didn't sign. Too bad for him. So despite everything that you do, sometimes if you don't cover all of your bases, you could still be held liable. So just do everything you can right, and then you'll be okay. What is the relationship between the signed refusal form and a patient refusal? Signed refusal form and a patient refusal. Yeah. A signed refusal is just that document. The guy, you'd like him to sign it, but he may not. But if he refuses, that's when he's saying, no, I'm not going to do it. You know, I'm not going to the hospital. So a patient can refuse, and that's going to be separate from a signed refusal. You may get a signed refusal. It's like, say you went on scene and the guy smelled really bad and he was really cranky, and the last place you wanted him to be was in the same vehicle that you were in. So you say, listen, why don't you just sign my refusal here, and then we'll get out of your hair. That's a signed refusal. Is that a patient refusal? No, that's a provider refusal, and that will land you in court. That was not a patient refusal. You didn't tell me you didn't want to go. I refused it. So I came up here and you said, I kind of got some chest pain, you know, I'm having trouble breathing. You smell really bad, or I know something really bad about you, or I just plain don't like it today. And you say, I've got this chest pain. And I say, well, have you got a neighbor or somebody that can drive you to the hospital? Here, sign this refusal. That's not a patient refusal, but it may be a signed refusal form. See the difference? I hope you do. If in doubt about a refusal, talk about it with the patient. You know, make sure that you're sure, that they're sure, that everybody's sure that they want to refuse. Make sure they understand. Call med control. Talk to a family member. I know these are all things you're saying. Didn't she just tell us that? You forget them, and they're so important. Call law enforcement if you're concerned that that you may need to take somebody against their will. Make sure you listen to the patient and find out what the barrier is, why they're refusing care. What are the risks of beginning treatment and transport without getting consent from the patient? Yeah, you know, and as I said, you don't have to say, is it okay if I provide care? You know, it doesn't have to be that formal. But if, you know, they are backing away from you and you're trying to get up here so you can take a blood pressure, and they, you know, they just keep going like this, or they go like this, and you kind of like peel their arm down, that's kind of refusal. So make sure that you're both on the same page. They want you to provide care for them before you start touching them up and stuff. What if the patient refuses to sign? We already did that. Things to consider during a refusal. As I said, a refusal is going to be when you're most vulnerable to legal action. It's going to be based on a refusal. Always have witnesses sign your refusal form. Who are going to be your best witnesses? Your partner? Police? And who else?
Family member.
Family members? Why? They're on their side. Yeah. Is your partner going to lie for you in court? Oh, he does? You bet. You probably will. It's like, I would do this for you, you do it for me. Yeah, so how valid is his signature that you actually went through the steps of refusal? Who knows? He's probably moral and ethical and, you know, he's not a liar, but there's always that chance he'll lie for you. Would your buddy, your roommate lie for you now? Probably. So, yeah, your partner is probably your least best signee. Law enforcement, fire department, whose side are they on? I hope they're on my side. You know, while they're good, they're not as good as a family member. If you've got a family member there, they're not so much likely to lie for you. Okay, so having their signature is probably going to be your best signature there. So try to get that first. Inform the patient. This is another important aspect of this, and you'll probably do this frequently too. Well, not so frequently, but make sure that the patient knows, if you change your mind, you can call me back. Our station is down the street. I'm not paid by the number of patients I see. I'm paid when you call me or not. I'm sorry if it's 3 o'clock in the morning, but this is what I do. So if you change your mind, call me back. Sometimes they'll refuse, and you've done everything you possibly can, so you can call, if you change your mind, if you start getting worse. One of the other things you ought to do is tell them what to expect if the condition progresses. You may have, say, somebody that's fallen and hit their head, and hit their head, and they're concerned they may have concussion, but they don't really want to go to the hospital because they're going to have to get all this tests and stuff. So you can say, well, you didn't have any loss of consciousness. Based on everything they've told you, you think it's probably not anything, but they're refusing. You can say, well, here's what will happen. You may start feeling drowsy. Your vision may start getting blurred. You may start, feeling sick at your stomach. You may have trouble staying awake. These are all signs that you could have a serious head injury. If you start feeling any of these, you need to make sure you call us back. How quickly is he going to start having those? Oh, yeah, I have that. I have that. Sometimes that puts them over the edge as far as being transported, but make sure you tell them what to expect if it progresses or get worse, and to know that they can call you back and you're not going to yell at them. If you'd gone with me the first time, all this would be over with. You can't say that. If you can't convince them to go, see if you can't have somebody to stay there with them, because once they're unconscious, what's our rule about consent? It's implied consent. So I had some friends down in Orange Beach, the fire department, they ran on this guy, and he had really bad chest pain, everything, this is going to kill you, and they refused to go. Well, they knew that it was just a matter of time. They kind of backed out and got in their trucks. They didn't even go back to the station. They just stopped down the street, it's about 10 minutes. The guy's in cardiac arrest, they go back and work the code. That's kind of rude, but it does happen. So ask if somebody can stay with them. Is there a friend or a family member that can stay here with you, to make sure you're okay? That's always helpful because they may call back. And make sure you document any patient encounter extremely well. Your cardiac arrests are always very long, but your refusals are even longer. I've had refusals that I've written several pages where I've actually put quotes and he said, she said, this, I said that, we did this, we spoke to this doctor, blah, 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 blah. So with refusals, you always want to document extremely well because you do not want to go to court over somebody else's problem. Okay, advanced directives. Now, advanced directives really don't apply to us except in one case. All the others are just fluff. So you'll see questions on tests and stuff that come up. The only advanced directive we care about is the one in bold. A do not resuscitate order or a DNR. A living will may be a document that a patient may fill out saying, well, if I get really sick, I don't want to be put on life support. If they're in the hospital, that's fine. Whatever, we're not going to put you on life support because that's what you want. If you go into a coma, you said no life support. So whatever, you can put that in a living will. They can have a healthcare proxy, which basically means that somebody else can make decisions about what they would want. Sometimes spouses will do that. If something happens to me, make sure that they don't, whatever. So that would be a healthcare proxy. Now, a DNR or any of these other things, it doesn't prevent you from providing palliative care or comfort measures. So don't think just because they have a DNR that you don't do anything for them. So think about what DNR means. Resuscitate. What types of people do we resuscitate or attempt resuscitation on? Yeah, dead people. Yeah. The only time we're ever going to do CPR on a patient is if they're dead. So if they're already dead, there's not a whole lot we can do about that. But if they have a DNR order, that means do not resuscitate. That means if I'm dead, don't try to bring me back. It doesn't mean if I have trouble breathing, don't give me oxygen. It doesn't mean if I have a blocked airway, don't try to clear my airway. All it means is if I'm already dead, leave me dead. That's what DNR means, okay? All right, you're called for a cardiac arrest. On scene, the family tells you that the patient has a DNR, do not resuscitate, and the patient doesn't want any resuscitative efforts, okay? So the patient has assigned DNR, that's what they want. However, one family member is very distraught. You've got to work on mama. You've got to save mama. Anyway, he says, is that what it says? Wants you to work on them, while others adamant that you're not. So you've got conflicting things here. Yes, save mama, work on mama, and the others say no, no, no. But now the final sentence says, he says the DNR is in the patient's records at the hospital. So, are we doing a resuscitation or not?
Yes.
Call.
They're busy. The patient's going to die before.
You would wait, and if it was not in your hand, you can resuscitate it.
Yeah, you have to have that document. You have to see that document. Because if you don't, you just got that he said, she said. What if you failed to do a resuscitation on this patient, and it was somebody that was leaving an estate of several $1 million, and the one guy, brother, sister, whatever, wanted mama to go ahead and kick the bucket because I want that money, and the other one really loves mama and didn't want mama to die. So what do you got here? You got to have that legal document, and you got to be able to see it and know that it's right. And then in this situation where I've got one says yes, one says no, I'm probably going to start CPR, and I'm going to call med control and say, here's what I have. And one thing you got to keep in the back of your mind too, when you got conflicting things here, are we sure this was just a natural death? Did somebody kill this poor person? You don't know. So if I'm not going to resuscitate, I got to know I got a DNR. It's not good enough to say, well, I know they signed one. It's here somewhere. Doesn't matter. We do CPR. When you find it, we'll stop. Okay? How will you handle this patient? God, I already told you, didn't I? What are you going to do? How are you going to handle this guy? Yeah, we're doing resuscitation. I might call med control. You know, if he says stop resuscitation, I'm good with that. It's too hard doing CPR anyway. So yeah, you will work that. Other legal issues. Negligence. This is important. Negligence is when something was not done or it was done incorrectly. That's negligence. Something you should have done and didn't. You're a chest pain patient. You should have given them nitroglycerin and you didn't. You should have given them oxygen and you didn't. Or it was done incorrectly. You know, you put them on a long spine board and, you know, you got their neck all cranked up or something like that. You did something wrong. That's negligence. In order to be found guilty of negligence, there are 4 things that have to be in place. And these are important 4 things. So put these in your mind. The other side must prove that you had a duty to act. That means it was part of your job for the day was to provide care for these patients. So that's a duty to act. And we'll talk about duty to act a little bit more in a minute. You breached that duty. So you had a duty, you breached the duty, which means you did not perform your duty. You either failed to provide the standard of care or you failed to act at all. So you breached that. You had a duty to do it and you didn't do it, or you didn't do it like you should have done it. Harm occurred. The patient suffered some kind of harm. And the last one, I don't know why it came up first. I'll have to work that out. Proximate cause, meaning you caused the harm. So if the patient has a bad outcome from something, they were drinking and driving and they ran into a tree and, you know, broke both of their femurs and nearly bled to death, the patient suffered some harm. You the cause of that harm? No, you didn't cause that harm. Now, if you grabbed them and drug them out of the car and they hit their head on the car and fractured some vertebrae in here and now they're paralyzed, is the patient harmed? Yes. Did you harm them? Yeah. Look at the other components here. In that case, you were working on the ambulance that day and you responded to that call. Did you have a duty to act? Yes. Did you breach your duty? Did you provide the standard of care expected? Would that be a yes or a no? Let's see. It's going to be a long night. Yeah. Yeah, if you hit their head on there and you cracked it and then you didn't provide stabilization appropriately, yeah, you didn't perform standard of care. Did harm occur? Yeah. Are you the cause of that harm? Yeah, probably. So yeah, that way, in this case, you could probably be sued and you could probably lose that case for negligence. But all 4 of these have to be present. What if you had a duty to act, you went there, you did everything right, You told the patient, I need to put you on this long spine board because you could have injured your spine here. Okay, so I need to put you on a long spine board. They go, I'm not getting on there. And so you say, well, if you're going to refuse, and you go through all the steps of the refusal, okay? You got to tell them, well, you know what? You could have a spinal injury. You could be paralyzed over this. You could have, some deficits for that. You've got to go through all those steps too if you're going to allow them to refuse something like a long spine board. So the patient refuses and you end up just putting them in the ambulance and you take them to the hospital and it turns out they did have a serious spinal injury and they end up with some deficits. Did harm occur? Yeah, the patient was harmed. He had a bad outcome. Is it your fault? Not if you did everything right. If you arrive on scene and it's a bad wreck, the patient says, my arms and legs are tingling, and you say, well, now let's go. It's probably a little swelling in there. Just come on over here and up to the ambulance. We'll take you to the hospital. And the patient has a bad outcome. Are you the cause of that? Now, they might have been the cause of the wreck, but you failed to provide appropriate standard of care. So, yeah, you're going to be liable for that. So you have to have all 4 components of that in place for them to win their case. Anybody can sue you for anything. They can sue you for being ugly, but that doesn't mean they're going to win it. But in this case, all 4 components have to be there in order for them to win that case. Duty to act. Duty to act is kind of interesting. If you're working with a volunteer fire department, do you have a duty to act? You're not being paid. Is that a duty to act? Yeah. If you've made a commitment to that department and you said, I'm going to be on shift from 7 a.m. to 7 p.m., I'm going to take call, whether they pay you or not, you've made a contract. So you have a duty to act, whether it's paid or volunteer. Now, if you're, say you're not at the station, you're a volunteer, and you're at home, and the little pager goes off, you don't have that duty to act. You don't have to go if you're in the middle of something. But if you're at that station and you said, I'm going to take call during this time period, whether you pay me or not, then yeah, you do have a duty to act. Breach of duty. If you perform a skill or fail to perform a skill up to the level that you're trained at, then you have breached your duty. If you don't perform it in the same way that somebody of equal training would have done it, remember we talked about that a few minutes ago, then you could be guilty of breaching your duty. Damages must occur. They don't have to be life-threatening for them to be damages. They just only had to have occurred. Now, what about this case? You have a patient that you have duty to act, and this is at the paramedic level, and patient's really made you mad. They aggravate you. She's called me every night this week at 3 a.m. and I've had enough. I'm going to fix that. So she says, oh, I just don't feel good. I think I had the flu. And so you say, well, I'm going to fix her. And you rummage around in your box, you find the biggest IV catheter you can get your hands on, and you stick that baby in that lady, okay? And you said, if you don't quit whining and carrying on, if you don't quit calling me at 3 o'clock in the morning, I'm going to stick you with the biggest IV needle I can find. And you stick her with it. Okay. So then you go on, and every time after that, she never calls again because she's scared to death of you. Has she been damaged? Yeah. You have emotionally scarred her. You can't do that. So yes, damage has occurred. It can be emotional damage. If every time she sees a needle now, she's horrified because of what you did to her, that's damage. And you were the cause of that damage. So yeah, it doesn't have to be physical cause. It can be emotional injury also. Refers to compensable, which means they will compensate you physical, financial, or psychological harm. So all of those can be damages. So don't be going out there and scaring your patients to death. Proximate cause, you have to have caused the damages. Any action or inaction that immediately caused or worsened the damage is called proximate cause. Now there could be a case where the courts may decide that the patient is equally at fault. So they assign, you know, damages that way. And it's a financial thing, and they may make you pay half of whatever it was. So abandonment, and we don't do this very often, but there are a few kind of gray areas that if you don't realize what you're walking into, that you could be guilty of abandonment. Once care has been initiated, you may not discontinue that care until care has been transferred to somebody of equal or higher level. So what that means is, if you're on the scene with somebody, say, with a possible spinal injury, as an EMT, and you're holding C-spine, we're going to learn to do that in the lab, and you're doing everything right, and then your phone starts buzzing, and you look at there, and it's your mom, and she's got some problems, and you go, I've got to go now, and you leave that patient, and you hope somebody else comes along. That's abandonment. You've got to stay with that patient until you transfer care to somebody at least your level or higher. Now, we have Good Samaritan laws. Almost every state has some form of Good Samaritan laws, but they're not all alike. But the purpose of a Good Samaritan law is to encourage people that are trained to provide care. Usually we're talking about the side of the road kind of issues, but it could be in a mall or somewhere. But they're encouraging people with training to provide care. And they do that by providing some kind of umbrella liability protection for them. And that's what a Good Samaritan law is. It doesn't apply to on-duty personnel, most commonly. So if you've got a duty to act, you have a duty to act appropriately, and that's your job. This would be you're driving by and you see a wreck on the interstate, and you decide whether you're going to stop or not. It doesn't cover you in all situations. It's going to vary from state to state. So make sure you understand what your Good Samaritan laws are in your state. And then you need to think about that in advance. If you are a witness to something or you come up upon a wreck on the interstate, you need to have decided beforehand if it's going to be appropriate for you to stop and render care or not. Sometimes yes, sometimes no. If you got 3 kids in the car, you better not be stopping, because you're going to be stuck with that patient until you can transfer care. I know for me as a paramedic, I've stopped quite a few times, and I could easily be caught on scene until another paramedic comes on scene. I can't turn it over to the volunteer fire department. Can't turn it over to ambulance staffed by EMTs. I have to wait for at least a paramedic or more. And so you may be stuck there until somebody comes along. So you got 3 kids in the car, you're not stopping and providing care. And we could go into more situations, but we're probably not going to. It does not protect you from gross negligence or doing anything illegal. Gross negligence is different than, gee, I made a mistake. It was an honest mistake. But if you do something like really stupid, or, if you're on the side of the road, you've got a pregnant woman and she's starting to have a breech delivery, and you pulled out a scalpel and you cut her open and did a cesarean, that would be a gross breach, certainly. So if you act out of your scope of practice or violate the law in any way, that could be a violation of that. Did you have a question? You're kind of making that frown line. Y'all okay with this stuff? Okay. Usually I have about 1,000 questions by now. Y'all tired? Bored? I'm going to have to fix that, I can see. Okay, here's one for you to think about. You arrive on the scene of a patient in cardiac arrest. The family says she has a DNR, but they don't know where it is. What should you do? Start CPR. Yep. You don't have a DNR, we're doing CPR. All right, you're off duty and you arrive on the scene of a vehicle crash. Police and EMS have not yet arrived. Are you legally obligated to stop and render care? No. Some people erroneously think that you do. They say if you've got a sticker on your car, that says you're an EMT, you're required to stop. No, you're not. But be careful about putting those stickers on your car, because you may get some really cranked people if they see you driving by and you've got this giant sticker across the back that says, I'm an EMT, I save lives. And they see you whizzing by. Every time they see your vehicle driving around town, they're going, you didn't stop, my family member died. So I don't have any of that stuff on my car. I'm kind of in stealth mode. So yeah, you're not legally obligated, but it's something you want to think about. Make that decision ahead of time if you're going to make those decisions to stop. Okay, the next little group we're going to talk about is intervener physicians. That's kind of a word, intervener physicians. I have to think about that. This is when you get called to Granny, she's having respiratory distress, she can't breathe, and you get there, and her son is there, and he's a physician. Are any of you guys family members physicians? What I say? Anything really ugly here? I won't say anything really ugly. But sometimes they feel like they know better how to manage that particular situation than you do. And if it's Granny and she's got respiratory distress, you know, yeah, if he's an ER physician or she's an ER physician, or, you know, they are a respiratory person of some sort, then yeah, they may know. But I've been to plenty of physicians' offices, and when you've got a crisis emergency and you're at the dermatologist is hoping that you're going to do something for that patient. So we really are trained to work and manage an emergent situation more so than most physicians are. They just don't do that kind of stuff. They go through ACLS and PALS in medical school, which is Advanced Cardiac Life Support. They go through that in medical school. When it comes to actually working a code, they don't do it, you know, unless they're ER physicians. So most of the time they're going to be uncomfortable in that setting, but sometimes they may be a problem for you. And some things you need to know. Here, I've got a scenario for you. You're called for, MVC is a motor vehicle crash. You're called for a motor vehicle crash near the local medical center. A man on scene identifies himself as a physician and begins to instruct you on how to manage your critically injured patient. So what do you know for sure here? What are the absolutes? What do I know for sure?
There's a critically
There's a
injured
crash,
patient.
there's a critically injured patient, and there's a man on scene. Do we know he's a physician? No. Do you really know if he's competent? Do you know if he's licensed to practice medicine there? If you turn over care to somebody that you don't know, they just say they're a physician, you're leaving yourself wide open for a negligence claim. So let's see. How do you manage this bystander? Back up. Get back. You're in my space. Is that it? So you like that? Not so much. Any other ideas?
What if he's got like ID or something? Good physician's ideas.
Yeah, like what did it say?
I don't know. I just know my dad
Dermatologist?
has like a little thing.
Yeah. What kind of doctor is he?
He's in the ER doctor.
See, we're okay with that.
Okay.
We're okay with that. But probably if he's working in your community, he's somebody that you know. And I've turned over patient care or worked with ER physicians before because I know them. But lots of times you'll have people that are not trained in emergency medicine. You know, they're gynecologists for heaven's sakes, or who knows what. Do you want them working your cardiac arrest? Or you want them to tell you how to manage a patient with a possible spinal injury? But you have to be diplomatic about it, because these are highly trained professionals. They're medical professionals. They know a heck of a lot more than any of us know. But in that narrow little piece of what's going on here, you really are supposed to be the expert here. So how are you going to manage this and not step on a lot of toes? That's really what we're looking at. How can you manage this to the patient's benefit? Turning that patient over, that critically injured patient, over to a dermatologist, for me, in my mind, is never a good idea. So some of them might be really good, but, you know, we have a burn or something. I know I said disrespectful. Please don't think it that way. I'm trying to make a point. So how can you manage that?
Ask them what they practice when they say they're a physician.
Is it really maybe they don't know him?
Call and
Let's come over
check.
here, let's talk about what kind of physician you are.
It's kind of new from some,
Do what?
yeah,
Oh, that sounds awful mean. Are we gonna like put them in shackles and stuff too? Call the police. What can you do?
You stop, just verify, call somebody to verify.
Step by, just stop them, step away, if they,
She's asking if you please come to your space.
or just tell them like, hey, like, I need your help, I'll actually you step right over there and
That could work, yeah.
diffuse the situation.
Diffuse is certainly the key here. Here's my recommendation to you. If you've got somebody that's adamant about instructing how you're gonna care for a patient, because here, if you turn over care to a physician, which you certainly can, they have to understand that they now are completely 100% responsible for that patient. That means they're gonna direct patient care, that means they're gonna accompany them to the hospital, that means they're gonna write up the patient care report that you would require for your service. They completely take over patient care. And most of the time, they don't want to do that. But that's just like us. We have to turn over care to somebody. We can only turn over patient care to somebody higher than us. He can't sit there and give you instructions and then leave the scene. You've taken over patient care, you've got patient care. So they do need to understand that. But being confrontational is never the answer here. The best way to manage this is going to be, you know, Doc, I appreciate, you know, what you're trying to do here. Would you mind speaking to my medical control physician at the hospital? And let the docs talk to each other, and they can sort that out. You know, we have protocols that we're supposed to go by. They work under a different set of protocols. But they're also going to have very limited equipment, too. And we're used to working with limited equipment. So that's nothing unusual. But in this event, unless they are really in your face and making it very difficult for you to do your job, you need to handle this as tactfully as you can and put them on the phone with your physician and let them sort it out. And then if you're the med control physician at the hospital says, turn over patient care, then turn over patient care and say, I'm here to assist you, tell me what you need me to do. Now, in the event that I was on the scene and an ER physician that I knew came up and, you know, started telling me what to do, it's like, how fast can I move? I want to help in any way that I can. When you get family involved, sometimes there are other issues there that are very difficult. So with a family member on scene, with a patient, I definitely want to put them on the phone with my physician. So anyway, the answer really isn't to be confrontational or call the cops. It's to handle it as tactfully as you possibly can. So do you do it? Oh, we already went through this. Do you ignore him? That never works either. Do you call the police? Probably not, you know, unless you felt in fear of your own personal safety. You've got to document everything very well. If they're going to take over patient care, they're going to have to do the documentation and do everything just as you would be doing. You need to clear it through your med control physician. Heaven forbid he made a mistake and turned it over to somebody inappropriately. And then if they manage the patient inappropriately, patient has a bad outcome, how are you going to feel? Not so good. All right, let's talk about confidentiality. Are y'all dying here? No, you're not. Okay, don't say you're dying. No. Okay, confidentiality. We have a legal responsibility to maintain our patients' confidentiality. As I said yesterday, or the day before, or the day before that, I can't remember, everything they tell you, everything you learn about that patient is confidential. It's for you and that patient, and then the only other people or persons that you can turn over that information to would be who? Yeah, anybody else that you're turning patient care over to. And you can share that information with your partner because you're both providing care. At the hospital, you're going to give a report to the nurse or the physician, whoever there. So you're going to be able to give that information to them, but nobody else. You can't, if the family member calls and says, oh, you know, they come running up and they say, oh, I saw you're taking my mom. What's going on with her? Do you know that that's her mom? Do you know it's a nosy neighbor? You don't know. But it doesn't matter because you don't have the authority, the legal authority to share that information. Only the patient can give that consent. So you have to be very cognizant of not giving out any confidential information. Only be shared with healthcare providers that are going to be providing care for the patient. Otherwise, it'll have to be obtained through a subpoena because your lips are sealed. Yes?
I know some testing takes, it's about for a police report, so can you use police for information in the police report?
You know, that's a really good question. And we may share some information with police. More times than not, we should not be sharing that. They should have to get it through subpoena also. They can go to the hospital. They can talk to the people there, but it's not up to us to give that information. You know, after you've been doing it for a while, you may find some ways that you can share information for the benefit of maybe victims, say. But you have to be really careful about that. You know, you might say, you know, this is a patient you might consider getting an order for a blood draw on or something. You know what I'm saying? HIPAA, we talked about this, Health Insurance Portability and Accountability Act. This is going to be the federal law that tells you you have to protect the patient's information. This allows a patient to be in complete control over their healthcare information. You can't share it without their approval. Okay, here's one for you. What's the difference between libel and slander? What's libel? It's what? I write something? Like what would it be? Alright. I hate you. False information. What if I wrote an editorial in the newspaper and my heading said, Mr. Jones has AIDS. He's very sick. Is that libel or slander? Libel. Now, what if it's true? What if Mr. Jones does have AIDS? We're grasping here. No.
Would it be liable if he does have it, slander if he doesn't, should that his reputation?
Well, libel means that something's written. If you think about libel, the L is legible, something you can read. So libel is something that you have written that defames someone. Doesn't matter if it's true or false. If it's intended to defame them or injure their reputation, which if you put in the paper, Mr. Jones has AIDS, it may be true, but it's really injured his reputation. So then certainly they could charge you with libel there. Slander is you said something. So you slander somebody by saying something. It doesn't have to be true or untrue if it just defames them in any way. Libel is false written communication. Slander is false oral communication, or not necessarily false. Oh, I have that up there. But if it's true but still injurious. The fact that the information released is true is not a defense to an action for invasion of privacy. So the truth of it is important, but not all that important. Res ipsa loquitur. Res ipsa, how many of you guys took Latin? Hey, somebody, a kindred spirit. Res ipsa loquitur means, basically, it means the thing speaks for itself. If a physician is performing a surgery in the OR, and say he's doing an appendectomy, sews the lady back up, and a couple months later she's going, God, that still hurts. That just still hurts. And they go back in, they take an x-ray, and there's a scalpel in there. Did she do that to herself? Probably not. The thing speaks for itself. It cannot have occurred any other way. Outside of physician staff negligence, it couldn't have happened. She didn't swallow it, and it landed down here. That didn't happen. So it couldn't have happened any other way. If you roll a patient into the hospital, and this happened, it wasn't me, somebody else, roll them in the hospital, they've got these burns on their chest where somebody's defibrillated them. The patient's going, man, my chest hurts. It couldn't have happened any other way. I don't know a patient that's going to go, let's see if this works. Not so much. So it couldn't have happened any other way. So that's res ipsa loquitur. So you may see that anyway. Okay, patient continues to have pain after an appendectomy. There it is. It's not really a scalpel, but anyway. Damage cannot have occurred without the negligence. Already said that. Patient did not contribute to the injury. Medical identification devices. I think we are getting close to the end, aren't we? Somebody watching. You may have a patient that has some identification on them that says they're a diabetic or they have an implanted defibrillator or something like that. So get in the habit for looking for those, because you may have an unconscious patient, you don't know what's going on with them, so you're going to have to really use your investigative skills sometimes to figure out what's wrong with them. So always look for those. Organ donors, legally, they may have a legal document that allows the staff at the hospital to harvest some organs. That does not affect our treatment of the patient in any way. If they have a DNR, we don't necessitate. Unless they also have a signed organ donor, and then I'm going to call the hospital and say, what do you want to do here? They may want you to do CPR just to keep the organs perfused until they can harvest them. But somebody else is going to make that decision. You don't want to let anybody die so you can get their organs, harvested. You know what I mean? You can't have your friends say, I really need a new heart. Can you get me one? Yeah, there's this guy would go on all the time. I can probably, anyway. Look for their driver's license. In some states, it's printed on their driver's license that they're organ donors. Sometimes you just carry a card behind your driver's license. You just want to let the hospital know that you're bringing in somebody and you've got documentation that they're an organ donor. Because they'll handle it a little bit differently based on that. Safe haven laws. The current safe haven laws, y'all familiar with those? A safe haven law allows a person to drop a child or an infant off at different places like the ER, hospital, or fire station so that, and it wouldn't be considered abandonment. You know, there was some time in the past where if a girl had a baby and she didn't want anybody to know about it, she might just like put it in the trash or, you know, try to flush it down the toilet or do something like that. Well, to prevent that type of thing, they've created these safe haven laws. And actually, this came out of Mobile. The first safe haven law came from there, and Alabama was the first one to institute this, where you could drop a child. Usually, each state has different ones, and they have different ages. Like I think maybe in Alabama it might be 5 and under. Some states, it's, you know, they have to be a newborn. So anyway, but so you may be sitting at work one day and you hear something. You open the door and there's, you know, Moses in a basket or something. So that would be kind of fun for you, don't you think? I'll probably name the baby after you. This allows a protection of kids that otherwise might have been abandoned or harmed or abused by the parents. Crime scenes. If you work in this business long enough, you're going to work some crime scenes. They can be kind of interesting. A crime scene is where a crime was committed, or if they moved it, it be any place where there's evidence. So our job, number one, what's our job going to be? Patient care. Law enforcement's job is, their job is the criminal aspect of that, protecting the evidence, that kind of stuff. So we got to remember what our job is always going to be patient care. Now, as long as we can do those things side by side, that's the best way to manage that. So we give good patient care, but we also don't disturb their scene. If you're on the scene, say, of a murder, you know, the first thing you want to know with the patient is, are they dead, or can you do something for them? If they're still alive, you're going to treat them like you would any other patient. But try to be a little bit more careful about disturbing the evidence. Now, in most cases, if they do have someone that's passed away, you're going to have to confirm that they actually are dead. You don't want to zip anybody up in a body bag and 3 days later find out, you know, they've been alive all that time. That's never good. So they may want you to confirm that the patient has actually passed away. So in that case, you may actually go in, you may touch a patient, but you just want to be really careful that you don't disturb anything. That means you don't go in there, you know, they're laying up on the sofa and you like run your arm like this and push everything off of the coffee table and set your bag down there and, you know, touch everything inside and, you know, bring 15 firefighters in there so you can, everybody have a look. What's that crime scene like now? What are the law enforcement guys going to do when they see you do that? They're going to hunt you down and they're going to kill you. Not really. They won't do that, but they're going to be very disturbed, and it's the last time you're going to be invited to their parties, I can tell you. So understand that they have a job to do and try to help them do their job while you do your job. So be very careful. And there's a lot in your textbook about this. Know what evidence is so that you take steps to preserve it. You know, don't be grabbing the phone. Don't grab up their cell phone and start going through it like this. No, don't do that. You know, if there's knives and guns laying around, don't pick it up and look at it. So what caliber is this? What, you know, don't do any of that. That's stuff you already know. Examples of evidence on a scene. The condition of the scene is important. When you document that, you want to document the patient, you know, didn't have any clothes on or didn't have their shirt on, or the front door was busted and broken, there was glass all over. The patient had glass on them. You know, there were blood splatters here or there. So you're going to describe the physical scene in your documentation because there's a real good chance you're going to testify on a case like this. So make sure that you're very observant and then you document everything very well. You want to document how the patient was positioned because that may tell everybody a lot about the injury and what actually caused that. So the clothing, what the injuries were. Watch out for leaving fingerprints. Anything that you touch on a possible crime scene, make sure you report that to law enforcement. Say, you know, I'm sorry, I had to touch these prescription bottles because I needed to know, you know, what the patient had taken. So make sure they know that, but try not to touch that. Don't have to. Watch out for leaving microscopic evidence around or disturbing any. Remember what you touch and then report it. Minimize your impact. Be a good friend with law enforcement on scene. If you transport them on the stretcher, save your sheets. There may be some important evidence there too. And then make sure you document very well. Now there are certain things that have what we call mandatory reporting. If you have a patient that you suspect has been smoking marijuana and they, ran up on the curb and, hit a tree, nobody was really injured, do you have to report that marijuana use? Who says yes? Come on, everybody. Who says no? Only the marijuana users are saying no here. I'm just teasing. No, we don't have to report drugs. There are certain cases that we do have to report, but we don't have to report drug use. Any time of abuse, elderly abuse, pediatric, domestic abuse, all those have to be reported. That's mandatory reporting. Any sexual assault or suspected sexual assault, you have to report that. All stabs, gunshot wounds, mandatory reporting. Animal attacks. Every time I got bit, it had to be reported. So animal bites. And then there may be some variations in local law and protocols and things that you have to report. But these are the ones that most commonly, nationally, you have to report. Who do you report this to? Call the police. Call the police. To the people I work for, my service. Who else? Do what? Your medical director. Anybody else have any thoughts? Actually, our requirement is to document it and report it to the ER. Once the staff there gets that information, they now are legally required to act on it. So that really is the chain that we go through. And that's the way it's set up. It works about best for that. Here we are. Let's see. There's a lot of stuff in this chapter for you to know. And you will see it. Do we have a test next week? Following week. Nobody cares. I'm glad to know you don't care. If a competent patient, what's the real definition of competent? How do you know if the patient's competent? Alert and oriented.
Communicate.
No, they are.
You might not be able to talk. Person, place, time, and event. Yeah, they got to know what's going on. You can't force them to go to the hospital. You can't force them to accept care. Negligence. What are the four components of negligence? Duty to act. Breach of duty. Harm. You cause the harm. Got it. Y'all are getting this. Abandonment. You leave a patient without providing for the transfer of care to somebody of equal or higher training. We are responsible for our patients' protected health information. They will hunt you down if you start spreading stuff. You take pictures on scene, post it on Facebook, they will come for you. It won't be me. Question to consider. Make sure you know what scope of practice is. Negligence, duty to act, abandonment, confidentiality. You need to know all of those definitions. If you want to put them on your note cards, I'm really good with that. Make sure you know what to do when a patient refuses care. What are the things you have to do if the patient refuses? You got to make sure what about their mental status? That they're legally competent to refuse. What else you have to do?
Tell them what could happen.
Make sure that they know what's wrong with them, what you think's wrong with them. What's the worst case scenario? What can happen if you don't get care? What else you got to do? Well, you certainly got to document. What's next before you do that?
Find out what the barrier is.
Yeah, why is it they want to refuse? So if you can't find out why that is and fix that, what else you got to do? Yeah, I'm going to try to enlist some help. I'm going to call a family member. I'm going to talk to the ER physician. I'm going to try to do everything you can. What else you got to do? If you change your mind, make sure they know. You can change your mind. You can call back. No big deal. So you got a lot of hoops you got to jump through here. And then finally is what? a signature. Hopefully you can get one. Who's going to be the best witness? Family member. Yes, sir. Well, so what if you're transporting a patient, you know, he's been all good with your care, and all of a sudden the closer he gets to the hospital, the more scared he gets. He goes, I don't want to go anymore. I'm not going. Stop this ambulance, let me out. Does that surprise you that a patient would do that? I had it. You're kidding, aren't you? So, what are you going to do?
Tell them what to do.
Yeah, I'm going to start through all that again. I'm going to say, well, explain to me what it is. Why do you want me to let you out? And short of him like freaking out, start punching you in the nose, hopefully we can just ride that out up to the hospital. You know, I may call med control back, but the last thing you want to do is stop the truck and let him out, right? Because what's going to happen? He's going to get hit by a car, and then the family's going to sue you. So, do you want to like restrain him now? No, they still have the right to refuse. So if he is absolutely adamant, you must let me go, then you have to what? Let him go. Now, I've had that happen before, and I just call law enforcement, and I'll say, I've got a guy, he's changed his mind, he wants me to let him go. I'm a little bit nervous about letting him out on the side of the road. And they'll just come up, they might talk to him, and then they can work it out however they want to, but it's not our problem anymore. Okay, here we go. You respond to a motor vehicle crash and you find a seriously injured patient. He has no pulse, and you're about to begin CPR when someone says, don't do that. He's got cancer, and he's got a DNR. No one at the scene has a DNR. Do you start CPR and transport the patient?
Yes.
Yeah, you guys are getting it. Yeah. It's a legal chapter. Okay, so tomorrow night we have, want to go inside 2 chapters? Yeah. 3 and 7? Yeah, those are some of my least favorite chapters, so make sure you read them well so I won't like beat you on the head with them, all right? Okay, see you tomorrow night. Y'all have been very patient. I appreciate it.